This meeting is being recorded.
Hi, everyone. I'm Enrico Escher, Executive Director of the Frank J. Veith International Society. I'm pleased and honored to introduce this excellent webinar to you. Dr. Peter Klovitsky, the current president of this society, was instrumental in putting this program together. Thank you, Peter. Please allow me to make some quick announcements. First, the Frank J. Veith Society is running its annual meeting in New York City on May 9th this year, in a few days, at the Hilton Hotel. Over 60 nationally known speakers will be presenting exciting topics in vascular surgery and endovascular therapies. More importantly, Dr. Veith will tell us how to succeed in vascular surgery, so you can't miss that. Please go to frankjvsociety.com to register. 2, also, the Society is organizing with the Semmelweis University the very first Semmelweis Vascular Symposium in Budapest, Hungary, on May 18th to 20th, 2023, and the program is online also in the same website, frankjvsociety.com. Lastly, an important reminder, you can now submit your abstract to the Associate Faculty Program at the Veith Symposium. Our society will be represented at the upcoming Veith Symposium with 2 sessions and an award competition. Please go to veithsymposium.org to submit your abstract. Registration for the program, however, for the November Symposium will begin next Wednesday. Today, we have a busy agenda, and we will include, which will include topics related to critical issues in the treatment of varicose veins. Dr. Peter Klovitsky, who is a Joe M. and Ruth Roberts Emeritus Professor of Surgery and Chair Emeritus of the Division of Vascular and Endovascular Surgery at the Mayo Clinic, will lead the presentations and discussion together with Dr. Alessandro Puggioni, who is a well-known vascular surgeon, super specialist in the management of venous diseases, and who currently is the medical director of East Vein and Lymphatic Centers in New York City. We are fortunate to have a cadre of experts to present important topics in the treatment of varicose veins, and another equally illustrious faculty to make comments and ask burning questions to the speakers. Without further delays, I will pass the privilege of the microphone to Dr. Klovitsky. Peter, please.
Thank you, Dr. Escher. It's a pleasure to be here with this distinguished faculty. It's also a real honor to be the president of the Frank J. Veith International Society. And I am so pleased that Dr. Veith could join us today. We are going to have an excellent program. Venous disease is one of the most prevalent of medical conditions, and we have had real progress in technology that helps us to treat patients with venous disease. And we are going to hear today about it, and I would like to ask again our co-moderator, Dr. Alessandro Puggioni, who is the medical director, as you heard, of East Vein and Lymphatic Centers in New York, to introduce our first speaker, Dr. Puggioni.
Thank you, Dr. Klovitsky and Dr. Escher. It's a great honor to be here this evening. I would like to introduce the first speaker, will be Dr. Andrea Obi from the University of Michigan in Ann Arbor, Michigan. And they will be speaking about compression for C2 disease. When, what type, and for how long? Dr. Obi?
Thank you so much for that kind introduction. I'm just going to preface this by saying 6 minutes is not quite enough. These are my disclosures. None are relevant to the talk at hand today. So the first question to ask is, why use compression for patients with C2 disease? Is it even useful? And that question was attempted to be answered recently in a Cochrane database review. One of the interesting things that came out of this database was that because all of the randomized control trials that have been done so far in the area of compression and venous disease have been so heterogeneous and at risk of bias that they're unable to come to any meaningful conclusion. But what we can learn from a few of the studies, at least 4 randomized control trials showed us that the benefits of compression include subjective improvement in symptoms, and 2 of the trials showed us that compression can objectively reduce edema for patients with C3 disease and above. And the risks overall of compression are pretty low. They're limited mostly to discomfort and compliance, which can be low due to the appearance of the stockings, issues putting them on, and skin irritation. Other risks like tissue necrosis are very, very rare. So when should we use compression for patients with C2 disease? Let's talk about a few different scenarios. So the first scenario is for initial therapy for C2 disease. Is compression suitable? Well, certainly there are some pragmatic considerations to take into account. So patients who have severe comorbid disease, who are non-ambulatory, or who prioritize avoiding any sort of surgical intervention based off of those trials I just showed, may benefit from compression therapy. However, I would caution that there's no data to suggest that compression causes disease regression or is curative in any way for patients with C2 disease. And most recently, a trial from the UK showed that compared to other therapies, interventional therapies, compression was amongst one of the worst choices in terms of cost effectiveness as initial first-line therapy for symptomatic C2 disease. What about as a long-term therapy option for patients with C2 disease? Well, at least 2 randomized trials have attempted to answer this question by randomizing patients to either receiving compression for a prolonged period of time or surgical therapy. And the results of these trials were remarkably similar, mainly that patients who underwent trial with compression over a number of years tended to do worse in terms of quality of life and symptoms over time compared to those who were treated with surgery. So in this scenario, certainly surgical intervention seems to prevail as a better therapy over compression. What about post-procedure? We know that there are several ways that we can treat patients with C2 disease, and certainly compression has a role here, and I'll highlight some of these studies in the upcoming slides. So for patients who undergo high ligation and stripping, certainly compression therapy seems to be beneficial. The same for foam sclerotherapy. It may not be indicated in patients undergoing cyanoacrylate axial vein closure. It seems to be useful in reducing pain after endovenous laser ablation. It's a little bit more unclear as to whether it's useful after RFA, and certainly in patients who undergo stab phlebectomy, it does seem to reduce pain. The summary of these trials is as follows. So most recently, the Confetti trial, which was done out of the UK, was a trial that randomized patients to receive either no compression or 1 week of class 2 compression after foam sclerotherapy of those varices. The main finding from this trial was that compression reduced pain following sclerotherapy out to about 10 days. The Veith study was one of the early studies studying cyanoacrylate closure of the axial veins. In this study, none of the patients were treated postoperatively with compression. And regardless, they all had an excellent closure rate, an acceptable rate of phlebitis at 20% at 1 month. So the findings from this study seem to indicate that cyanoacrylate is well tolerated without any post-procedural compression. What about thermal ablation? A recent meta-analysis of over 1,000 patients entered into trial who underwent radiofrequency ablation or laser ablation demonstrated that pain improved in 1 week after therapy in patients treated with compression in the EVLT group. However, the benefit didn't seem as clear in the RFA group. And finally, the recent COMETA trial was a trial that randomized over 200 patients undergoing endothermal ablation, either laser or RFA, with or without concomitant phlebectomy. About half of the patients had phlebectomy. The findings from this study indicated that patients who had concomitant phlebectomy had improvements in their pain score if they were treated with compression. However, those improvements went away when they dropped the patients with phlebectomy out of the trial. So what type of compression should we use? There are multiple types of compression that can be used in patients with superficial vein disease. However, the most common is elastic compression, and this is comprised of compression stockings, short stretch bandages, or long stretch bandages. There have been at least 5 different randomized control trials that have looked at different compression regimes after surgical treatment of C2 disease. And I'll try and summarize these very briefly, although it's a lot of data. The main finding from these studies suggests that an increase in the level of compression, and you can see the classifications over on the right, so going up from a class 1 to a class 2 or from a class 2 to class 3, is associated with improvement in pain at 7 days post-procedure and is associated with fewer complications. As the trade-off is that as you go up in class of compression, there does seem to be more skin irritation. And then the technique of eccentric compression, which basically refers to putting padding along the surgical site and then layering your compression over the top of that, seems to be associated, again, with improvement in pain and less major complications. What about duration of compression? So we now have trial data extending from about 4 hours of compression after surgery to a full 6 weeks of compression after superficial vein interventions. What is known so far is that it doesn't seem necessary to keep patients compressed for longer than 2 weeks. The outcomes are very, very similar at 6 weeks regardless. The difference seems to be in that early compression at 48 hours versus 1 week. So this is a study looking at just patients undergoing EVLT, 775 analyzed in a meta-analysis. And what was found here is that there was better postoperative pain scores when patients were kept in compression for 1 week compared to 24 to 48 hours. So just to summarize, this is the state of the current guidelines. So the 2022 multi-society guidelines really suggested that for patients with symptomatic C2 disease who are candidates for intervention, that they should undergo intervention over long-term therapy with compression, given the more favorable outcomes. And then the 2019 multi-society guidelines really suggested that we should try and use compression after surgical treatment of these patients, and that when we do use compression, we should use at least 20 millimeters of mercury and use the eccentric padding to try and give patients the least amount of postoperative pain. And that's all I have. Thank you.
Thank you, Dr. Obi, for your wonderful presentation. Definitely a hot topic now is the need for 3-month compression before any intervention is performed as required in the US by insurance companies, and definitely we need a study for that. I have a little comment and a question. What about those patients that undergo ablations without phlebectomy and have very large veins? They seem to thrombose pretty easily right after those procedures, so will be indicated to apply compression stockings by default in those patients.
Yeah, I actually completely agree with you. And I think one of the shortcomings we have in the superficial vein world is we don't have a way to grade the severity of the varicosities. So I worry about the same thing. And for patients with large varicosities, I often try and do concomitant phlebectomy. And if I can't, even if I'm doing cyanoacrylate closure, which technically doesn't require compression for vein closure, I try and compress the vein or put them in stockings afterwards to limit thrombophlebitis. So I wondered if you did the same thing, because I do think it really depends on the size of the tributary bed, but we just don't have a common way to talk about that because there is no, commonly used classification.
Thank you. We are fortunate to have a Dr. Frank Veith, the founder of this international society, with us. Good evening, Dr. Veith.
Hi there. Listen, Andrea, I thought your talk was excellent, very clear. I have a question relating to some of the newer air bladder devices, like the AeroWrap, to create pressure. First of all, we know it's very hard for some people to put on elastic stockings. The AeroWrap, which uses various easy methods for a person to apply the thing, and then inflates an air bladder to a given pressure, which can be monitored with a gauge. Seems to me like a simple device, much simpler than using elastic stockings or other complicated compression devices. Could you comment on that? Are you familiar with it?
Well, I can comment. I can't comment specifically on that because I haven't used it. I will say that you're right, the major issue is getting the stockings on, and we often tell our patients to get gardening gloves, or we try and help them get a Don and Doffer or Butler. I love that concept of what you described. We haven't had the chance to use it. What I'll often use if I can't get a patient in elastic compression is I'll have them get a ComproFit, which is an inelastic Velcro based dressing that is easier to put on. But I agree, like, because compliance is really limited to about 40 to 60% in trials, the easier we can make application, the better the results are going to be for the patient.
Right. I mean, the AeroWrap uses Velcro. Patient can easily apply it, can take it off if there's a dressing, with an ulcer or something, they can change the dressing. It's a lot easier to use. And I just think that all of you venous experts should perhaps look into it.
I would love a link.
Thank you, Dr. Veith, Dr. Aubie. We're gonna move on to the next speaker. It's with a great honor that I would like to introduce Dr. Monica Golowiecki, Emeritus at the Mayo Clinic in Rochester, Minnesota, will be speaking about adjuvant venoactive therapy is effective in patients with the varicose veins. Dr. Golowiecki.
Thank you. So let me just go into sharing the screen. And all set. Okay, I hope that you can hear me well. Okay, so thank you very much for your nice invitation to talk about the venoactive therapy in varicose veins patients. And here is my disclosure. So first of all, I would like to underline the fact that those venoactive drugs or medications are widely prescribed for patients with chronic venous disease all around the world. Although in the United States, most of them are only available as a nutritional supplements. And as you can see in this table, most of the substances belong to benzopyrones family, with the supplement like diosmin, rutoside, hesperidin, and micronized purified flavonoid fraction. Only a minimal part of them are synthetic drugs, such as calcium dibesilate. And these substances have really well-recognized mode of action, which varies for different compounds. It includes an effect on venous tone, venous wall and valve, capillary leakage, lymphatic drainage, hemorrhagical factors, antioxidant and anti-inflammatory properties, and protection of endothelial function. These properties are all of interest when the varicose veins treatment is considered. In the clinical practice guidelines of the European Venous Forum, the International Union of Angiology, and the Union Internationale de Phlebologie, venoactive compounds earn a strong recommendation for CVD with level A scientific evidence for MPFF and suggestion of benefit for Ruscus extract and other venoactive drugs. Just recently, the European Society for Vascular Surgery in 2022 guidelines included venoactive compounds in the algorithm of treatment for symptomatic patients with CVD who are not undergoing interventional treatment, who are waiting for intervention, or have persisting symptoms or edema after intervention. 5 venoactive drugs are available in the United States as nutritional supplements: diosmin, micronized purified flavonoid fraction, MPFF, Ruscus extract, horse chestnut seeds extract, with main substance acin, and red wine leaf extract. MPFF is composed of diosmin in 90%, and hesperidin fraction in 10%. The micronized formulation increases the intestinal absorption and improves the drug efficacy. The data from systematic reviews and meta-analysis in chronic venous disease were available for all these VADs except diosmin, and helped to establish the beneficial effect of adjunctive venoactive pharmacologic treatment for varicose veins. The level of scientific evidence varies from high for MPFF and Ruscus, moderate for horse chestnut extract, and a moderate low for diosmin and red wine leaf extract. In the meta-analysis of MPFF, 5 of 7 RCTs included C2 patients, so purely varicose veins patients. The authors concluded that based on high quality evidence, MPFF was highly effective in improving symptoms, edema, and quality of life in patients with CVD. In the RELIEF trial that confirmed efficacy of 6 months treatment by MPFF, 40% of patients had uncomplicated varicose veins. The value of MPFF adjuvant treatment was also confirmed in patients who had interventions for varicose veins. In his systematic review, Professor Mansilla concluded that treatment with MPFF may help reduce post-procedural pain, hemorrhage, and CVD-specific symptoms. One of 4 meta-analyses of the Ruscus extract identified 10 RCTs versus placebo in patients with chronic venous insufficiency. All these studies included variable percentage of patients with varicose veins associated with edema and skin changes. The authors concluded that based on high quality evidence, Ruscus are highly effective in reducing symptoms and edema of patients with chronic venous disease. As for horse chestnut seeds extract, the Cochrane systematic review focused on chronic venous insufficiency, where some patients had varicose veins associated with edema. The authors concluded that the evidence presented suggests that horse chestnut is an efficacious and safe short-term treatment for CVI, even though they list existing caveats and advise larger definitive trials to confirm the efficacy of this treatment option. Among the beneficial effects observed, symptoms and edema improvement were significant in placebo-controlled trials. This review included a Lancet published trial showing that compression stockings and horse chestnut therapy might be alternative treatment for patients with edema. Red wine leaf extract in a systematic review by Astari demonstrated a beneficial therapeutic effect in CVI patients, including patients with varicose veins. And in conclusion, the systematic reviews and meta-analysis included heterogeneous cohort of CVD patients, frequently with chronic venous insufficiency. Current evidence strongly suggests the beneficial effect of venoactive drugs on venous symptoms such as leg pain, leg heaviness, and sensation of swelling in patients with varicose veins. And I will finish with the quote of William Mayo, that the best treatment, the best interest of patient is the only interest to be considered. Thank you very much.
Thank you, Dr. Glowicki, for the wonderful and very informative presentation. Definitely a lot needs to be studied for varicose veins and lymphedema. We have an array of medications for arterial disease and cardiovascular disease, and with the high prevalence of venous disease, more needs to be done for sure. With these supplements, which are pretty cost effective, and most are quite inexpensive, some of them have some cross allergies with nuts and other common allergies. Do you have any recommendations on what questions we should ask patients before prescribing those medications in terms of genetic allergies?
So as far as I know, the allergies for these supplements are pretty rare, but allergies might happen in anything existing in this world. So of course, you know, if you have the patient with multiple allergies, maybe that is something to be considered. But as far as I know, this is really minimal. And the only, you know, the relatively present side effect of these supplements are gastrointestinal disturbances, which can be controlled by the administration with the main meal.
Thank you.
Well, I'd like to thank you for the opportunity to pose a comment and a question for Dr. Kovitsky. It was a fabulous talk. You've obviously got a wonderful legacy in participation in creating this validated, quantified data that we have the opportunity to read in your career. And this is a rare adjunctive therapy that complements all of the therapies for veins, millimeters to literally down to the 5-micron level. So given that much of the data is European-based, and it's phenomenal, trustworthy data, however, how do we help our colleagues in the United States understand this data better? And are there trials and studies that you would propose to be done in the United States that further help validate and quantify for acceptance within the United States as an adjunct to our therapies to improve outcomes?
So I think that certainly I would encourage any clinical trials with these supplements. And as far as I know, like right currently, we have in Canada ongoing trial in the post-thrombotic syndrome, which is always a headache for many physicians. And I think that I'm looking forward to see the result of this trial conducted by Susan Kahn. And I think that it will be a very valuable input to appreciate the true value of this treatment. And other than that, I think that, the proof of the treatment efficacy was pretty well done in the ulcer treatment. We had the several randomized control trials. We had the meta-analysis, which was really a key proof for the efficacy in these indications.
Thank you.
Thank you very much, Dr. Kovitsky. All the information about these medications that may be hopefully useful for our patients in the future in the United States as well. It's a real pleasure to introduce my compatriot, Dr. Stephen Deak, who is from Somerset, New Jersey, Rutgers Robert Wood Johnson Medical School, New Brunswick. And Stephen is going to talk to us about polytoconol endovenous microfoam, a new and widely used or increasingly used medication. And he's going to tell us if it is safe and effective for both saphenous ablation and varicose vein treatment. Dr. Deak.
Thank you. Polytoconol endovenous microfoam is safe and effective for both saphenous ablation and varicose tributary treatment. My disclosures, I've been consulted for Boston Scientific, surgical and thermal ablation has been very effective in treating the reflux in the greater saphenous vein above the knee, but has limited success in treating the varicosities below the knee. Polidocanol endovenous microfoam is FDA approved for the treatment of symptomatic varicose veins with reflux of greater than 500 milliseconds or half a second and up to diameter of 26 millimeters. There has been a concern in the vascular community about the safety of polidocanol microfoam and its long-term patency results or closure results. A retrospective study was performed of 1,070 patients treated with EVLA or polidocanol microfoam and followed for 3 years. Polidocanol microfoam, unlike physician compounded foam, is made with extremely low nitrogen content, and the microfoam has uniform density, size, and stability, which makes it safe and effective for venous ablation. Retrograde chemical microfoam ablation is performed by cannulating the greater saphenous vein with a 5 French micropuncture catheter. The first 5 ml of foam is injected in an antegrade direction. The second injection of 5 ml of foam is performed through the same catheter in a retrograde fashion by placing the examiner's hand in the mid-thigh, allowing the foam to go in a retrograde fashion through the incompetent valves to the ankle. It should be noted that the leg should be elevated 45 degrees to decrease the blood in the veins. Here's a symptomatic patient with reflux of 1.83 seconds, diameter of 16 millimeters, treated with 8 mLs of polidocanol. The polidocanol microfoam can access areas of tributaries below the knee that are not accessible to surgical or catheter-based techniques. As you can see, the foam is in the ankle area after injection in the upper thigh. The polidocanol endovenous microfoam is visible in the greater saphenous vein as well as the accessory branch of the greater saphenous vein above the knee. And after injecting the foam, the greater saphenous vein is non-compressible in the ankle area. (1,070) patients were treated. 520 patients were treated with EVLT. Their age and sex distributions were similar. And of the 520 patients, the initial closure rate was 92.8%. In the group of patients treated with polidocanol microfoam, 550 patients, the initial closure rate was 82.9%. 17% of the patients required a second pre-planned treatment to obtain a closure rate of 93.5%. The residual patients had to be treated because there was residual reflux in the below knee segment. The FDA limits the amount of foam that could be administered at any one time, and 20% of the patients need a second treatment. The preoperative symptoms were fairly similar in the two groups, mainly aching, pain, swelling, and 18% had skin or ulcer problems. The characteristics of the veins were very similar. The vein diameter was the same. The reflux in the two groups was the same. The length of vein that was treated in the polidocanol group is longer because the polidocanol could go below the knee. 79 joules were used for each centimeter of vein treated in the EVLT group, and 10 mLs of foam was used for the patients. Here's a patient with a non-healing ulcer for 16 years. He had multiple surgical and ablative procedures performed, and he had a healed ulcer for over 1 year after treatment with polidocanol. The results of 520 cases of varicose veins treated with EVLA revealed 92% of the patients had closure of the greater saphenous vein. 18% of these patients required a redo procedure for recurrent symptoms within the 3-year follow-up period. DVT was present in about 0.8%, and there were 2 E-hits. 5% of CEEP6 ulcers healed in 30 days. Of the 550 patients treated with polidocanol, complete elimination of reflux was noted in 93% of the patients. A second treatment required 17% of the patients with residual reflux below the knee. 22% of these patients had a previous failed thermal ablation. There were no neurologic or cardiac deficits in the 550 patients. DVT was noted in 0.4%. There was 1 common femoral vein thrombus extension and 4% of SVT. 69% of CEEP6 ulcers healed in less than 30 days. In conclusion, polidocanol endovenous microfoam is effective in eliminating reflux, helps wound healing in C6 patients with minor complications, and is a durable alternative to the current treatment modalities available to physicians. Thank you very much.
Thank you very much, Dr. Deak. This is an extensive experience that is beautifully documented. Thank you for telling us about this new treatment option. The discussant will be my good friend, Peter Lorenz, who is from Los Angeles, UCLA Medical Center. And Peter is going to ask his burning questions. And I'm sure that he's going to make a comment because they also have experience with this treatment. Peter?
Thanks very much, Dr. Deak. I know you have an enormous experience, and we have, I would say, a moderate experience. And 2 areas where we've found it particularly helpful are in the patient with the anterior accessory saphenous vein, which is often tortuous in the mid-thigh and below, so you can't put in a straight radiofrequency thermal catheter or laser catheter, and also below the knee, because you don't have to worry about the risk of nerve injury in patients, the CEEP6 patients that you showed that have venous ulcers. So those are 2 areas that we have found it to be particularly useful. You talked about 2 things, safety and effectiveness, and I would just point out that in the approval of the microphone, that the incidence of what I would call ART, A-R-T-E, ablation-related thrombus extension, it's not E-hit because it's not thermal, but that there was about a 7 to 8% incidence of that. So the first question is, do you routinely do a duplex ultrasound several days after the procedure when you're going to do a saphenothermal or saphenopopliteal junction? And then the second one is that the effectiveness, we found that although it's great in closing saphenous vein, that the superficial phlebitis occasionally occurs in tributary veins where we've had to do a small IND or use anti-inflammatories. So tell us how you manage the superficial phlebitis if it occurs in a tributary vein.
Well, thank you for your question. We routinely do a follow-up 3 to 4 days after each exam, each treatment, and we haven't found that high incidence of common femoral vein thrombus extension. We follow the polidocanol as it approaches the saphenofemoral junction, and we compress it so to limit it. We also ask the patients to dorsiflex their leg. But the key point is that we empty the veins after the cannulation is performed and before we treat it, because that way we take a large dilated vein up to 26 millimeters and make it small, allowing the foam to interact with the endothelium. We also place these patients in elastic compression stockings, 20 to 30 millimeters for 48 hours, thigh high. That limits the amount of blood that ends up going into the superficial veins. The 4% of superficial vein thrombosis was in those patients who have very big varicosities superficial to the skin. And those two things have helped us quite a bit.
Thank you very much, Dr. Deac. We are going to continue the presentations and we'll talk about inappropriate procedures that are clearly not in the best interest of our patients. And the title of the next presentation is Inappropriate Procedures for Varicose Veins Could Be Markedly Decreased by Appropriate Change in Reimbursement. And how to do that, Dr. Russell Sampson is going to tell us from the Florida State University College of Medicine, the Moat Vascular Foundation. Dr. Sampson.
Well, thank you, Peter and Enrico, for inviting me. This is my disclosure. So I think before we start about why are there still large numbers of inappropriate procedures and how to stop it, we need to know why we're actually having all these inappropriate procedures. And I think the main reason is currently there's still no national carrier determination for the treatment of veins. There are multiple local carrier determinations, some of them even from the same company, with actually different criteria as to who should or shouldn't get treatment. Each one of the insurance companies has different requirements. And until recently, Peter, with all the work that you've been doing, we've really had no specialty agreement on guidelines. And then, of course, I think as everybody knows, patients have now become a commodity. And all over the country, we're seeing these advertisements for the treatment of varicose veins, many of which I think are unnecessary. Also, I think the major problem is that the treatments can now be performed in the outpatient arena where there's actually no oversight. And in these places, we are finding that many of the providers have complete lack of education. Many of them have probably only been to a 2-day course, some not even to one of those courses. Many have no formal education. And a recent report showed that there are almost 35 different specialties that are treating people with varicose veins. And I have a personal bias that I think there's an excessive emphasis on treating the clinical significance of truncal reflux. In as much as perhaps a lot of people that have truncal reflux really don't need to have treatment, even if they have reflux. A big issue I think that I've seen around the country is false advertising, claiming that there are risks if these patients are not adequately treated. And there's definitely fraud in the venous market. So all the different criteria that are up there from guidelines as well as the local carrier determinations, they all use similar guidelines and similar criteria, such as you have to have a duplex scan, there has to be clinical evidence, there has to be more than C2 so-called disease, there has to be truncal vein reflux, there's discussion about saphenous vein size, and there's also a need by some of the various insurance companies to show duration of conservative care. What I'm going to suggest is that we become quite draconian with these criteria, not only incorporate these criteria, but change them or make them better defined. So for example, a duplex scan must be performed in standing or in reverse Trendelenburg. And we need to see that in the chart. It has to be defined by the technologist and by the report. And we need to see that they've actually used calipers to actually define reflux, not just eyeballing in reflux. As far as a duplex scan is concerned, we have to insist that the technologist is an RVT, that I would suggest that the provider should be board certified in vascular surgery, interventional cardiology, or interventional radiology. Or if they're not in one of those specialties, they should have the RPPI, RVT credential, or they should at least, at the very least, work in an intersocietal accredited lab or an equivalent certified lab. Ideally, I would like to see it board certified in the 3 specialties that I described above. As far as clinical evidence, we don't want to just see this written in the report because the doctors know how to doctor the report. So we need to have photographic color evidence of the disease. We need to see the varicose veins. And if there are skin changes that are described at the ankle or at the leg, we need to see color photographs of these. And on top of it, we need to see the actual duplex scan. Simply seeing the report is not sufficient, again, because we know that by looking through many, many insurance claims that the physicians know how to doctor the report as well. So we need to see a well-defined picture, preferably in video, but at least a color photograph, and it must show all the appropriate annotations. As far as C2 asymptomatic disease is concerned, I personally don't believe that insurance carriers should be required to pay for this treatment unless there is documented associated skin changes and axial reflux in a truncal vein. Personally, I believe that C2 disease is a cosmetic condition. So if we're going to treat C2A disease, the documentation must not include statements suggesting that the patient will come into harm if they don't undergo treatment. And at the same time, the documentation should include that loss of the saphenous vein. The patient needs to be adequately informed, and we need to see that they have been through a good information process. As I said, C2A is a cosmetic condition. If you don't know what C2A disease looks like, I usually know that I can see C2A disease simply by looking at the distribution of the veins. In fact, often it spells it out on the patient. And if you still don't know if the patient has C2A disease and they're just trying to game the system, ask them that if I do the procedure and all that happens is your pain goes away, but your veins remain behind, will you be happy? And if the patient looks like this, then you know they've got C2A disease and they're not symptomatic. I believe that we should see truncal reflux that should be along the entire axial course of the truncal vein as defined by the new guidelines, not just reflux at the junction of the deep vein. I personally believe we should insist on truncal vein size. In the absence of skin changes, we should see that the great or accessory truncal veins must be at least 5 millimeters. I know this is debatable, and I know there's data that suggests that small veins can still be associated with symptoms, but I believe a lot of these papers are subjectively biased and therefore not reliable. And in fact, I believe it's simply physics. Retrograde flow will be less in a narrow vein. So I'd like to see an enlarged vein in these patients. As far as the duration and type of conservative care, we need to insist that there are at least 2 clinic notes. This will prevent a rush to treatment, and it will show that the patient has been adequately advised about what needs to be done. And one of these then should be, one of these notes should be dated prior to treatment. And if stockings have been used, there should be proof that the patient actually bought them. So let's see a receipt. I certainly believe that stockings are beneficial as per the first speaker today. And I think stockings post-ablation are a good dressing. That's what we use in our clinic. And so if they have to buy the stocking, to try it out before and see if it actually helps them, so that's so good. And certainly if we ultimately come to do the treatment, they've got a stocking as a good dressing for the treatment. So in conclusion, I think strict criteria applied by the insurance companies may create a burden for all providers, but hopefully it will possibly prevent unnecessary procedures and patients won't have to hear this from their doctors. And that concludes my talk.
Thank you very much, Dr. Sampson. Dr. Karen Rockman from New York University Langone School of Medicine is going to be our discussant, and I'm sure that Dr. Rockman will also make some comments.
Thank you. Thank you for the opportunity to discuss, and I was thrilled to see that I'm able to comment on Dr. Sampson's work, because he always gives such a thoughtful presentation on this subject. And I actually agree with almost everything that Dr. Sampson says. I think all of us who work in this area have seen patients who have either had multiple procedures by another practitioner or have been recommended to have multiple procedures by another practitioner, and they walk into our offices and we look at them and examine them and do an appropriate duplex scan, and we don't think that the patient really has venous reflux or venous disease at all. So this is clearly a problem. Having said that, while I agree with almost everything Dr. Sampson says, I think it's a little bit idealistic. And how are we actually going to do this? And I find, for me, one of the most mind-boggling things is the duplex scan itself, because I will have a patient who comes in with a duplex scan from another institution that shows marked reflux, and I repeat every scan because I will not intervene on a patient for venous disease unless I've done a duplex scan in my office with my technicians. But an outside scan will show reflux everywhere, axial reflux, and I show none. It is wonderful to say that all labs should be IAC accredited, but I just don't know that that's realistic. The other thing that I want, my other burning question, if I'm allowed a second one, and Dr. Sampson and I have talked about this before, is with regard to C2 disease, because I certainly think there is a certain demographic of patient who really is coming in primarily for cosmetic concerns, yet has read on the internet and has been told to say these buzzwords: my legs are heavy, I have discomfort, and whatnot. And certainly that category of patient exists. But there is also a real category of patients, elderly patients with very large C2 disease without axial reflux, who I think really benefit from quite simple microflebectomy procedures. So thank you again for the opportunity to comment, and these have been great talks so far. I look forward to more discussion.
You know, when we do these talks, we try to be a little bit more dogmatic than we need to be, I think. But I do believe it's up to the insurance carriers to rein in the people that are abusing the system, because the abuse is out there. And you can have all the guidelines, Peter, and your guidelines are terrific, but these people are not reading them or they're ignoring them. So I think we have to be draconian, and I think the insurance carriers have to clamp down. And I would suggest that they ask for everything. And you know, I agree though with you, Karen. There are going to be some people with large varicose veins who don't really have symptoms, but those veins are getting in the way. They have a little bit of itching and something, and they should be done. But the true C2 cosmetic patient the insurance carrier should not have to pay for.
Thank you. Definitely hot topic, will deserve a session of its own. I would like to introduce the next speaker, Dr. Kathleen Maxfield from Danbury Hospital in Danbury, Connecticut. And the talk will be about tips and tricks for safe and durable great and small saphenous vein ablations. Dr. Maxfield.
All right, let me get the Hi, so I'm actually presenting today for Dr. Alan Dietzig. He was unable to be here. So I think that he's given this talk several times, but it's a review of the tips that he's gained from long experience in the closure procedure just with RF. So I don't have any disclosures related to this presentation. I think that even an easy procedure can sometimes be hard. And with vein ablation, it starts with accessing the vein. This can really be technically challenging. I think that a vein can be measured as larger, and then you get into the office, it's a small vein. You can have vein spasm. And then having limited experience with the procedure or minimal experience with using the duplex yourself can be problematic. If you are the ultrasonographer while you're doing the procedure, it's essential that you become facile with the duplex probe. Be familiar with your duplex machine. If the simple adjustments, such as adjusting gain to brighten or darken the procedure, or adjusting the focal point to enlarge the view, this can make a world of difference for your access. Also, learn to access the vein in short and long access views. The long access view is when you align the needle and the probe. This provides a larger duplex target for needle access. And then if you go through with the needle and then you pull back slowly, you can watch the back wall pull up, and this confirms that you are interluminal. The short access approach, I think, is probably most useful when the vein is very superficial or deep. You center the probe over the vein and then put the needle a little ways away from the probe in the center and puncture so you can see the needle entering into the vein. In the awake patient in the office, particularly for very nervous patients, vein spasm can occur. This can be upsetting for everyone, including the patient, and turn a short procedure into a long one. Keeping the room warm, putting the patient in reverse Trendelenburg, and keeping the patient calm by talking and having music can help prevent this. If you do have vein spasm or a smaller vein, dilation can be achieved with nitro paste or warm compresses. And alternatively, you can just move to a new access site. In the outpatient setting, again, with an awake patient, tumescence can be painful. One of the techniques most commonly used is to inject local anesthetic, mark the vein, and then inject with a small gauge needle prior to inserting the tumescent syringe. Using a pump is very helpful. It saves time and helps patient discomfort. Additionally, I find it much more, I find it easier than working the syringe with my single hand while I'm running the probe on the other hand. Other ways of minimizing discomfort in the awake patient, apply ice on the skin. It's free and it has an immediate onset. Ethyl chloride creates a temperature drop with rapid evaporation, and this causes a temporary anesthetic effect. I think lidocaine creams and sprays are good. They're a little longer onset, but they're not very expensive and they last a while. Occasionally, you'll have difficulty passing through segments of vein that are tortuous or have webbing. I always forget that just repositioning the extremity, having the patient move their leg, or using manual compression can solve most of those problems. A guide wire is always useful. It avoids delay and discomfort of repeating attempts of passing this area. And if the guide wire doesn't work, just place a second sheath just proximal to the tortuous segment. Sometimes in post-phlebotic segments with webbing, you can just poke through with the RF catheter. That often works. I think often there are occluded segments. We don't need to pass through this. Just place a second sheath proximal to the obstruction and don't waste time. With superficial veins, I think RF should be used cautiously. It can cause skin discoloration. If you discuss that with the patient, sometimes they're not worried or bothered by that, but if they are, then it is a contraindication to use it. Additionally, skin burns can occur, and this can be avoided with adequate tumescence. Most of the closure devices that we use have sort of a longer and a shorter treatment length, but with very short proximal axial vein segments, really we shouldn't be using these devices. You need a minimum number of centimeters to allow for the forward heating of the catheter. And then in recannulized or post-phlebotic veins, consider non-compounded foamed sclerosant or phlebectomy only. So even in, easy procedure can become quite difficult, but everything should be made as simple as possible. Thanks for your attention.
Thank you. Thank you, Dr. Maxfield, for sharing your tips and tricks. Definitely having a sonographer in the room is a luxury, but there are things that they can be added when one prefers to do the procedure without a sonographer, adding a second or third screen in the room, or utilizing probes with buttons so they can zoom in and out, save and freeze. So they're tools so they can definitely help, as you suggested, performing those procedures without extra help.
Yeah.
I would like to invite the discussant, Dr. Charles Ditzik from the Vein and Vascular Institute in Voorhees, New Jersey. Dr. Ditzik.
Hi there. Good evening. It's a pleasure to be here with all of you. Dr. Maxfield, I enjoyed your presentation and all the tips and tricks you provided. I think one of the things you did mention was having a table that can go into Trendelenburg, and going into reverse Trendelenburg certainly is a helpful tool that the expense is well worth it when you're doing these procedures on a regular basis. One of the issues I found is dealing with more and more patients that are over their ideal body weight, the obese patient. Do you have any tips and tricks for those kinds of patients that we often see now more frequently than ever?
Yeah. So I guess, you know, moving the pannus by placing the patient into Trendelenburg and accessing where the vein is close, like below the knee to the skin. And also you can use, you know, a tributary from the greater saphenous vein to get access to the greater saphenous vein. Those would all be suggestions.
Excellent. It's certainly, you know, having a nervous patient. I know you mentioned using nitropaste, and I have found that to be helpful in that patient that has a smaller vein that is resistant to responding to just gentle talking and getting them to relax, that using some nitropaste and waiting 5 minutes, you'll find that the vein will dilate nicely. And that is a technique I've used myself as well. Have you found any other tricks with regards to the ultrasound machine in changing some of the settings and to help you? We find that by adjusting the depth on the ultrasound machine can make the vein look larger than it actually is when you're looking at something that's 5 centimeters deep versus looking at it 2 centimeters deep.
Yeah.
Psychologically, that seems to make the vein look bigger, although it actually is not, and it make access into the vein easier.
Absolutely.
But I enjoyed your talk, and thanks for all those tips and tricks.
Thanks.
Thank you very much. We have quite a bit of time for discussion, and I see that Dr. Veith is still with us. And Dr. Veith, we need to ask you about inappropriate procedures. This is such a major issue in this country, not only for venous, but for arterial procedures. And as you heard from Dr. Sampson, 35 specialties do venous ablations. As far as I know, only psychiatrists don't do venous ablations.
Not yet.
So tell us what you think about this issue and how could we make it better?
You're muted, Frank. Frank,
I think you are muted. You're fine.
First of all, I enjoyed all the talks. I think they were really right on target and great. And I congratulate you and Enrico for really a very good webinar. We're dealing with human nature, Peter, and unfortunately, that's hard to change. I think Russell's talk was right on. I think Karen Rockman was right on that it's going to be difficult to put into practice because people have ways of getting around all sorts of regulations. So I think it really represents not just the problem for vascular surgeons, it's a problem for our whole society. Certainly in many other specialties, they do unnecessary procedures. GYN is one example of that. And I guess we need to develop better consciences in physicians and get the money out of the equation, although that seems to be everywhere, even in the upper levels of our most prestigious institutions. They care more about dollars than they do about quality. I don't have an easy solution.
Dr. Lawrence, you championed appropriate use procedures. Is it something that we could do as a society or as a specialty to decrease inappropriate procedures?
Well, I think it's a critical issue. I'll just point out that Lucian Leap, who was the chief of pediatric surgery, spent the end of his career when he was in Boston at Harvard School of Public Health addressing this exact issue. He estimated at the time 30% of surgical procedures done in the United States were inappropriate. And I think it's probably higher than that now. And if you think about it, we could take care of every patient in America if we just didn't do inappropriate procedures. So it's an enormous problem. Things that I've thought of are, number one is for certain procedures, maybe only pay half in the beginning and half a year or two later if whatever people did worked. That would be one possibility. Other possibility is mandatory second opinions. You could say if you're not trained in those three specialties with venous disease, you have to have a mandatory second opinion from someone who's not a colleague, someone who's truly independent. I think that's a second possibility. And then for people who are truly fraudulent, I think we have to, as a society, we have to both exclude them from our societies, but also I think we need to have prosecution of those people. Unfortunately, malpractice is the only way right now, but the IG office and the federal government, I know looking into this, and I'll just mention that I've had 2 calls in the last month, one from the New York Times and one from ProPublica, that are interested in this project of inappropriate care in vascular disease management. So I think the last thing is publicizing it.
Thank you very much, Peter. Enrico, you have a comment?
Yeah, I just have a contrary comment, just to start the discussion. Let's take a 25-year-old lady and a 26-year-old man who come to your office, and you give them the gown, and they complain of itching, but the itching is an excuse because they have all these varicose veins in both legs, thighs, legs. Look like a map of veins. And they are traumatized by it. They're psychologically traumatized by it. It's not that it's hurting, it's not, but they can't go to the beach, they can't go out, it's limiting their social life to a point that getting them depressed. You think that these patients should be denied insurance coverage because they are poor and they cannot afford to pay. So we have to look at, it's different from doing an angioplasty on a 50 or 60% SFA stenosis. But you have to take in consideration the negative psychological effect that these ugly veins causes on people. They can change their lives. What do you think about that?
Peter, that might be a question to you.
Sure. Well, I think for every one of those, there's 100 that come in with a duplex ultrasound being told that they need to have ablation of 6 or 8 veins. And as I think Karen Rockman said, you do it and you don't find a single reflux. So there's no question that there are people, and you could say cosmetics should be an indication. There would be still a possibility of a second opinion. And I think in our society now, you could say the same thing about the psychological impact of a person who has a facial deformity or needs to have a facelift or something. So once we decide that all cosmetic things should be paid for by the patient, I'm not sure why we would exclude varicose vein, or why we would make an exception for varicose veins. So I think it's a good argument. People do have psychological issues related to it, but in the current climate and in the current reimbursement system, the far greater issue is fraud. People who have nothing, they have no veins, they're being treated by a physician who's had no training in this disease, and it's a way for them to make an inappropriate amount of money for doing this procedure. So I think you have one patient, Enrico, and I think that's a very legitimate patient. For every one, there's 50 or 100 others that are on the opposite side that don't need anything done.
And Enrico, you can do that for nothing yourself. You don't just do it when that patient comes and you feel that strongly, don't charge them. And by the way, when you get your hair transplant, I'm interested if the insurance is going to pay for it.
I must say that Dr. Sampson works for an insurance company and he's represented them very strongly nowadays, when before he wasn't.
All right, why don't we go ahead if anybody has a question to any of the speakers. Panelists, go ahead, or discussants, go ahead. Yes, Mark Mellin.
So I've got a question on the opposite end of the spectrum. We've seen in our wound clinic in the last 6 weeks, 3 patients come in with ablations for what was a diagnosis as a VLU. One was a scleroderma patient with an ABI of 0.7. One was actually a basal cell malignancy, and one was a pyoderma. So how do we improve diagnostics with venous leg ulcers so that we're appropriately doing ablations and not losing conduits that may be necessary in the future? I think diagnostics for VLU is very important. It may be thermography. Clearly, we have a rising epidemic of obesity and diabetes that I think is going to complicate the situation, but diagnostics for venous leg ulcers, I think, has to improve. And we may be overestimating the number of venous leg ulcers in the United States.
Dr. Deak, how do you treat your patients with a venous ulcer? Do you get special diagnostic studies or biopsies? You are muted. Go ahead.
I did not include one of my favorite slides that I wanted to because of time constraints, but I had this patient who was 95 years old, and she had a 3-centimeter venous ulcer that came to my office. She had had a previous ligation and stripping of the greater saphenous vein, and I treated her with Unaboots for 3 years because I said, well, there's absolutely nothing to be done for her. I have to rely on Unaboots. Then one day she had no insurance because Medicare wouldn't cover this procedure in the past. I studied her, and to my surprise, she had an accessory branch of the greater saphenous vein that started above the knee that measured 6 millimeters in diameter and had a reflux of 8.6 milliseconds. And I gave her 5 mmLs of polidocanol, and she healed the ulcer in 30 days. At first, we thought she died. We called her up, and she was fine. 2 months later, we called her again. She was fine. So for 3 years, I treated her with weekly Unaboots. She received 136 Unaboots, and all it took was 5 mmLs of polidocanol, and it cured that lady. So I think you have to be very careful before you say that it's something else.
All right. Dr. Obi, is Unaboot? You didn't talk about Unaboot.
Yeah, because I was talking about C2 disease.
That's right. So tell us, I have some questions from the audience online about the cost of many years of compression therapy.
Yeah, so I was gonna send, I saw Anil ask that. I'm gonna send him the paper. So no one's done, as far as I know, a cost analysis in US dollars, but the way that they adjusted for it in the UK paper, you can actually sort of apply it no matter what system you're in, but they did take the cost of the initial therapy, the top off therapy, if it was an interventional treatment, and then the cost of compression stockings, and they included in their analysis quality adjusted life years. So what benefit the patient was going to get, as well as the actual cost of the treatment. And that's how they came to that formulation. They projected it over a period of 5 years. So it'd be nice if we had that, and if someone in the US would do the same study, but I think it's pretty compelling to take into the quality of life as a component.
Dr. Deak, you have a comment?
I do know that the yearly cost of venous leg ulcer treatments for the United States is over $13 billion a year. So that's a very high cost. And a lot of it is inappropriate. It includes skin grafting and appligraft and everything else that is very not cost effective. Una boots are inexpensive. They've been around for 100 years. And they work. So the problem with the Una boots is that you could heal the ulcer, but it keeps coming back unless you treat the venous hypertension, which is underlying the ulcer. And Dr. Linton has been trying to do that since 1938. Other people have tried interrupting the perforators, which I think have not worked. And the results of the study we found was that you could convert the ulcer healing, improve it by healing the hypertension from a remote access site. So you don't have to inject the polidocanol at the ulcer site. You could inject it above the knee and it will heal the ulcer if you treat the underlying venous hypertension. And that's really the takeaway in my mind.
Thank you, Dr. Deak. First, Dr. Rockman, and then we get back to Dr. Mellin.
You know, I have a different question, and I was just talking about this with one of my colleagues in the past few weeks when we talked about treating the below the knee great saphenous vein. And certainly we probably all see patients that we've treated the above knee segment and they continue to have significant symptomatic reflux related to the below knee great saphenous vein. And I heard several of our speakers today, I don't have a personal experience with polidocanol, but I've heard people say on this talk today that you shouldn't use endothermal ablation. And I actually have done that in a patient whose vein is not that superficial, and I think it works quite well. But what really amazes me is most people on this call, I think, or people who are my age or older, certainly remember before we had these endovenous techniques and we would strip the great saphenous vein, we would strip it from the ankle to the groin. And I'm wondering why we didn't worry so much about a saphenous nerve injury then, and we're so worried about saphenous neuritis now.
I think we are worried about burn more than evulsing the nerve. Yeah. But I think you bring up a good point, and there is plenty of evidence in the literature that you can treat infrapopliteal truncal veins with thermal ablation, but most of us have some concerns that there is saphenous and certainly sural nerve injury. Dr. Mellin, you had a question?
Well, I just wanted to compliment Dr. Deak on his excellent results in using polidocanol around in C6 to eliminate that significant local venous hypertension. But just to introduce dermal lymphatic dysfunction stasis, so phlebolymphedema, of course, is the catchword. And we just can't forget that the dermal lymphatic system is a significant part of the high recidivism rate. And I think if we appropriately treat dermal lymphatic stasis, improve lymphangion functionality, of course, MPFFs, I think, are a significant part of that. We use that routinely in our practice. We can increase not just ulcer rate healing, but also decrease recidivism rates. And I think there's a good economic play to that because Dr. Deak, you spoke to the significant, and I'm at the National Wound Care Conference right now at SAWC in Washington, D.C., and I'm walking among all the skin substitutes and all the conversations, and we're trying very hard for next year to have a significant part of this conference be a half-day all-in discussion of lymphatics, CVI management, lipedema management, the lymphatic dysfunction of diabetic foot ulcerations. So I think lymphatic component for restoration and decreasing recidivism is an incredibly important topic.
Let me ask Dr. Monica Glowitsky if there is really evidence that MPFF or Ruscus helps patients with venous ulcers, and maybe in this country, patients with venous ulcers should also take one of these compounds that you were talking.
So certainly there is an evidence, and there is a indirect and direct evidence. First of all, as Mark very brightly pointed out, you have a lymphatic component and you have edema component related to venous disease, and whatsoever edema component is actually related to lymphatics, because as we know now, every chronic edema is related to anatomic or functional lymphatic insufficiency. And we have certainly for MPFF a proof of the enhancement of lymphatic drainage. And this translates into the clinical effect on the edema, first of all, and secondly on the in the effect on venous leg ulcers. And I was recently looking into the studies with MPFF versus control group. One part was versus placebo, and one part of the studies were done versus just control. And in fact, the difference in the healing rate between MPFF and control group was as big as you have the difference in EVRA trial. So in fact, when you add MPFF, you add a significant component to improvement of your patient's state in ulcer. So, and this is, I think that you cannot have the most objective proof for the treatment efficacy than ulcer healing.
Yeah. Can I ask a question? I think that a lot of the reasons that people get recurrent ulcers and recurrent problems is these people that have advanced ulcers get a secondary lymphedema. And those people need to continue to wear stockings. And this I think it's a fallacy to think that you've done this treatment, it's over, you don't have to worry, and you don't have to ever wear stockings again. So I like to incorporate stockings early into the treatment of these patients and to let them know that they should continue to wear them, not religiously, but as much as possible.
Andrea, what kind of stockings do you recommend to varicose vein patients? And you mentioned that some studies or RCTs did not show disease regression, but would these stockings help with the symptoms?
Yeah, that's a great question. So, I mean, I think in practical terms, I recommend to patients whatever they can get on, because that's the limiting factor, right? It's getting something they can be compliant with. The most common thing that I prescribe in my practice is class 2 20 to 30 millimeter mercury stockings, and probably the second most common is the thigh high version of the same thing, and the third most common is the ComproFit, which it allows them to use the elastic or the it's a non-elastic dressing, but allows them to use Velcro rather than to pull the stocking on. And there are at least 4 randomized trials that did show a benefit in terms of patient symptoms. The issue, I think, with some of the trials is there's obviously the issue with blinding, right? They're heterogeneous, and then some are so dated that they just use, like, for instance, a visual analog scale to measure discomfort rather than some of the more up-to-date quality of life scales that we are used to using. In fact, there's only one RCT, I think, that included a quality of life scale for patients, but certainly at least 4 RCTs show that symptoms are improved in patients with superficial venous insufficiency in the setting of wearing compression stockings. So
Peter?
it can be useful.
Sure.
Yeah, Peter, can I ask a question? Because I'm not an expert in this field, but it seems to me that these ancient remedies that have worked for years, which require us to put the dressing on, like the gel cast boot or whatever, should be replaced by some higher tech technique. I mentioned the Aero Wrap the Circade dressing, something that the patient can easily take off and put on. All of these experts should come up with a better device that doesn't require the older devices, which require return to our care and we have to reapply the boot and so forth. So what about coming up with a better technology that allows pressure, healing of the ulcer, and the patient can wear it without returning to our office?
We developed the Jobs Ulcer Care, which is a zippered stocking and an inner liner compress. So you wear an inner liner stocking that has 15 millimeters of mercury pressure that keeps the dressing in place. It's very easy to put on. It has a very low coefficient of friction so that you can easily put another stocking on. And that stocking has the Nobel Prize winning device called the zipper. And the combination works very well. So for people that have a minor ulcer, it's a terrific dressing, very easy to use.
It looks like, Russell, you suggested to patients with ulcers or pre-ulcers, but Mark, do you have some recommendation for varicose veins?
Well, I was going to say on the ulcer component, we're using it's called edema wear. So it leaves the ventral medial bundle, of course, is the main way for the lymphatic function along the saphenous vein. And 70% of the lymphatic flow is in the dermis, and there aren't good perforators, as the Swami study from Australia showed in 2018. So we're really focused on how do we get lymphatic stasis resolved. By wearing edema wear, it's micro deformation, much like positive pressure therapy, and acts kind of like the struts within the foam of negative pressure therapy. And by stimulating that dermal reduction, and that's only 8 millimeters as a sleeve, and we put that under inelastic compression, so it's still easy to do the dressing changes, and the combination of static Circade or inelastic compression with that active dynamic dermal interaction, that's where we see significant skin volume reductions. And I think reducing that subcutaneous edema, which is what's allowing restoration of nitric oxide production from the shear forces. And that's where we're seeing the vasodilatation, the lymphangiectatic contractility, as well as the adjunctive component. So I think that dynamic dermal interaction plus overlying static has really helped us in terms of resolution and lowering the recidivism rates. And we're not using a lot of these products that I think really accelerate the cost of care when you're talking $100 to $110 per square centimeter. So this has allowed us to get away from adjunctive skin substitutes, which we're now actually called camps, to get patients healed. And I still think, in those patients that need it, a split thickness skin graft is absolutely the best way to go if we have to get to that point.
Peter, there's a question from the audience that the viewers talk about the deep system more proximally for these non-healing ulcers, venous ulcers. I know Peter Lawrence have written a paper saying that the combined vein ablation and repair of an internal common iliac vein, the combination of both achieve better healing. Peter, can I ask Peter to comment on this?
Sure. Well, there are really 4 ways to treat ambulatory venous hypertension: the truncal veins, which we've talked about, the perforator veins, the tributary, and the proximal iliac or proximal. And I think what we don't know now is what the order is or what it should be. Most people start with the truncal, the saphenous, great saphenous, small, interaccessory, just because it's a lower cost, simpler procedure tolerated by the patients. As you know, there's Dr. Raju who thinks just the opposite. You got to start with the iliac, proximal. But I think most people in the United States now would say the tier would be superficial truncal, and if there are associated tributaries, perforators if the ulcer doesn't heal. And if that doesn't work, then try an image, because you have to do the iliac veins, you probably have to have an MR or CT scan of the proximal. Ultrasound often doesn't see it. And then, so it's a much more expensive procedure. But I think the timing of which is done first is something. I just want to mention with Karen Rockman's point about below the knee, we never had an option or an alternative to stripping. So most of us did stripping and probably only damaged the saphenous nerve 5–10% of the time, but it would still occurred. And I find that the patients that really benefit from Varithena or some mechanism of closure of the below knee saphenous vein are particularly C5 and 6 with lipodermatosclerosis, firm, hard tissue, you can't do good tumescence in those patients. So thermal ablation is not a great option. And I don't think stripping through fibrotic tissue is great. So that's why we have this great option of using optical ablation.
No, I certainly
use
agree
them-
with that. And those
Oh.
patients with a lot of induration and that kind of tissue, then definitely thermal ablation is not a good option.
Peter, one
All
minute.
right, you can heal 100% of venous ulcers if you use all of the armamentarium that we've talked about, from compression to, skin grafts occasionally or skin substitute, but all of the techniques for venous disease, 100% of venous ulcers, in my opinion, should be healed.
All right.
Enrico,
Now, just saying that we have to
go for it.
finish finish it. So all I have to say is thank you very much. It was a very elaborate discussion, very interesting, very deep. I personally learned a lot, although I've been doing vein procedures for many years. And I can see that Dr. Veith all of a sudden got a lot of interest in the subject. And I think we're going to see more vein procedures at Veith Symposium in November. So thank you all. It was a great webinar. Thanks a lot. I'll
Thank
see
you,
soon.
everybody.
Bye-bye.